Good morning, seniors and colleagues, and thanks Dr. Assis for inviting me to deliver this talk. Today I am discussing about the TKR in severe valgus knee. Although the incidence is about 10% of the normal TKRs what we do, but India I think the numbers are little less. More common in females, rheumatoid arthritis, renal osteodystrophy which usually present as a windsweep deformity, and the rickets which is left over and present as the genu valgum, later on left untreated, and later on present with the valgus knee. So coming to the classification, it's the type 1, 2, 3. But in this lecture, I am going to cover the severe valgus knee. So most important thing is the clinical examination. First, you have to see the magnitude of the deformity. Most of the deformity which looks like a very severe deformity that may actually be correctable up to normal. So you have to first see whether it is correctable or not, or degree of correction what you can achieve with the anesthesia only or with just the various forces. Skin condition is very important, especially in cases of rheumatoid arthritis where your skin could be like a paper thin. So you have to think of it. You have to also see the previous scars as we check in the normal TKRs. You have to see the FFD. Usually valgus knee present with severe FFD, and severe valgus and severe FFD, there is high chances of peroneal nerve injury. So you have to keep in mind range of motion is important to see quadriceps strength. Patellar tracking is usually disturbed in valgus knee. So you have to plan your incision according to it. Because if sometimes the patella is fully dislocated, then you don't have the option of going middle parapatellar approach. A neurovascular status have to be mentioned. Sometimes patient may present with some form of peroneal nerve injury, maybe mild form of peroneal nerve injury. So coming to the what are the challenges in severe valgus knee? Tight lateral or posterolateral structures, bony defect of the lateral condyle. Usually there is a defect in the femur which is hypoplastic, but sometimes you find the defect in the tibia. Rotation of femoral component is difficult to manage on the table because we all use the posterior referencing. Most of us use the posterior referencing. So in this case, special techniques have to be used. MCL attenuation have to be checked. Instability could be a problem after final releases. And peroneal palsy, as I have already discussed. So coming to the surgical approach, most of the deformities can be managed by medial parapatellar approach, but sometimes you should know the lateral parapatellar approach, which have to be added with the tibial tubercle osteotomy. In some of the situations like the situation you take care in valgus knee with dislocated patella, you don't left with much of the options. So you have to go with a lateral, with a TTO, and also you need to medialize the tibial tubercle. But at the end, you might not find anything on the lateral side to close your wound. So these conditions are difficult to manage. This is a 3-month follow-up. You can see well healing of the TTO. Implant is in good position. Patella is also in the place. But this patient developed the skin problem, which later on we need to take the plastic surgeon's opinion, and they actually did the flap. So these are the tough situations. You have to keep in mind that something like this could also happen. Bone resection, if you see that the medial side is opening more than 1 centimeter, then you have to undercut the tibia and femur both, like we do in the severe varus knee. Normally we cut in the 5 degrees of valgus. Here we have to revise it to 3 degrees of the distal femur. Maybe after the cuts, you may not cut any of the portion on the lateral condyle of the femur, but you have to build that part. Tibial resection at 90 degrees as we do. Tibial slope should be normal like we do it. Femoral component, if you see in this, the dotted line in the picture is the actual position the lateral condyle should be. But in this case, usually there is hypoplastic lateral condyle. So if you go by posterior referencing, then that is that is not reliable in this case. So you mark your transepicondylar line and white sheet line and go 3-degree external rotation. In these cases, navigation, robotics helps you a lot. And after the cuts, you check for the symmetry of the flexion gap. Tight lateral structures are iliotibial band, posterolateral capsule, LCL, popliteal tendon, lateral gastrocnemius, and lateral hamstring. They all are tight in severe cases. The structure which has distance to the knee joint are usually contribute to the tightness in the extension, while the structures which are close to the joint like LCL and popliteus, they are tight both in the flexion and extension. So coming to the sequence of release, what should be the sequence of release? So as per the Ranawat et al. Work, we usually release PCL in all the cases. So CR knee is not an option for severe valgus knee. First PCL is released, then coming to the posterolateral corner, either you release at the tibia level or you do the pie crusting, then the pie crusting of ITB, and at last you do the pie crusting of LCL, or you can completely release it. In Ranawat method, usually the popliteus tendon is left. So first, balance in extension, do the posterior capsulotomy after putting on the lamina spreader on the lateral side. First balance in the extension, then check the flexion, and if required, do the pie crusting of the LCL, or you may release also. In the severe cases, you might need to release the LCL. Now coming to the prophylactic peroneal nerve release, should we do or should not we do? There is 4% incidence in the valgus knee, but in severe knee where the valgus is more than 25 and FFD is more than 10 degrees, various workers have shown the peroneal nerve injury as high as 30%. So for me, valgus knee more than 25 and FFD more than 10 degrees, and if the deformity is rigid, then I go for the peroneal nerve release during the surgery before doing the TKA. Release done near fibular head. Usually it is tethered here. The vertical intermuscular septum between the peroneus longus and extensor digitorum lumbus muscle acts as a compression point. So release your peroneal nerve here. Lax MCL. If it is highly attenuated, then there is no point of saving it. You have to straightforward jump to the varus valgus kind of constraint. But if the medial ligamentous stretching or attenuation is there, you can do the advancement of MCL and division and imbrication both. Implant option, in most of the cases where deformity is correctable or partially correctable, you can go for the PS. In many cases, you may need semi-constraint, especially when the MCL is severely attenuated. And if you completely release the LCL, go for the semi-constrained one. Fully constrained, like rotating hinge is usually not required. Now coming to the case, this is 62-year female, 25-degree valgus, 10 degrees FFD. You can see the pre-op X-rays. This is the post-op. You can see clearly that there is a separate incision given here for the release of the peroneal nerve. Case 273-year, more than 20 degree, partially correctable. Here we manage with the PS knee. Again 55-year valgus, more than 20 degree, it is also partially correctable. So manage with the PS knee. So coming to the valgus specific complications, two is the most important. One is the peroneal palsy, as discussed already. Second thing is patellar instability could be persistent, or there is chances of AVN if you release from the lateral side. Medial parapatellar incision plus lateral release may lead to the AVN, and the incidence is as high as 15%. Thank you.
Thank you, Dr. Ratnesh, for your elaborate presentation. Now it's very important to be on time, so we'll stop here and we'll go there for inauguration. Thank you.
May I request Chairperson to felicitate, sir, please? Any and a group photograph. We'll break off for the inauguration. The Professor Honorable Binde sir has already arrived, and just Sajanand sir is in between Chiriatar Pool and Hotel Moria. So by the time we set up,